Okay, hello everyone, welcome, good morning. It is our fourth episode of our Ensuring Equity in Aging webinar series. Very pleased to have everyone here today. Next slide. And welcome. Today we will have live captioning streamed through the webinar. At the bottom of your screen, you should see a CC button that you can click to access the closed captioning. We also have American Sign Language interpretation available through the webinar. All of today's slides, the recording, and the transcript will be posted on CDA's webpage in our Equity and Aging Resource Center, as well as that the presentation recording can be found on CDA's YouTube channel. Next slide. We have reserved 10 minutes this morning for questions and comments. If you are online on the webinar on your tablet or computer, go ahead and just, you can raise your hand if you'd like to ask the question at the end of this webinar, or go ahead and enter in your question in the Q&A, and we can also try to address your question that way. If you are logged onto audio by phone, go ahead and press *9 if you have a question, and you'll be added to the queue for the end of the webinar Q&A session. If you have any other questions, comments, always feel free to email us at engage@aging.ca.gov. Next slide, please. So this webinar series we have every month, the first Wednesday, at least through July 2021, perhaps longer. We will always feature national, state, and local leaders with expertise in the subjects of cultural competency, equity, and service delivery. Next slide. I hope you can join us next month. We have, our focus will be on culturally responsive policy and programs for Asian and Pacific Islander older adults. We'll be joined by June Bang of the National Asian Pacific Center on Aging and Yvonne Sun of SSG Silver, a service delivery organization down in Los Angeles. You can register in advance on our webpage. Kim McCoy-Wade will be joining us later in the presentation. She is our director of the Department of Aging, but has been pulled to work on some vaccination work at the moment. Obviously, very important and urgent work right now. Next slide. So I am so pleased with our lineup today of our speakers, such a great breadth and depth of knowledge regarding the health and well-being of Black older adults. So first we will hear from Dr. Jonathan Butler. He is an assistant professional researcher in the Department of Family and Community Medicine at UCSF. He is a social epidemiologist and a minister with interest in the role of religion, childhood experiences, and psychological stress on health outcomes. He's also actively involved in projects in two primary domains: psychosocial stress and type 2 diabetes risk and obesity, and community-based participatory research focused on obesity across the life course. He was appointed to the Sugary Drinks Distributor Tax Advisory Committee in San Francisco, known for a lot of fantastic work, and has also been responsible for things such as leading efforts to provide more than 2,000 fresh produce bags to vulnerable adults in San Francisco in collaboration with both private and nonprofit partners. Dr. Butler completed both his PhD in medical sociology and his Master's of Divinity at Howard University, and completed his postdoctoral fellowship at UCSF's Department of Medicine. Following Jonathan, we'll hear from Lisa Tealer. She is the executive director of the Bay Area Community Health Advisory Committee, which is a community-based organization focused on eliminating health disparities in diverse communities across generations. The committee has an inclusive approach to this work by partnering with several organizations through health education, connection, and to resources and advocacy. Prior to that role, Lisa has spent over 30 years in the biotech industry in technical and management roles, supporting clinical trials and manufacturing processes, and in human resources roles, specifically managing a wide range of diversity, inclusion, and equity initiatives. Lisa also serves as a community advisory board member for the UCSF Helen Diller Family Comprehensive Cancer Center and COVID-19 research, Sequoia Hospital, and the Stanford Cancer Institute. Due to the pandemic, she joined the REACH Coalition to increase equity and community health for all. In addition, she is a member of the Equity Recovery Group and the Vulnerable Population Support Committee for San Mateo County's COVID-19 long-range plan recovery initiative. She has an undergraduate degree in biology from Mills College and a diversity management certificate from Bauer College of Business at the University of Houston. And finally, our third speaker today will be Dr. Leondra Clark Harvey. She is the Chief Executive Officer of the California Council of Community Behavioral Health Agencies and the Executive Director of the California Access Coalition. She has previously served as Chief Consultant to the California State Assembly Committee on Business and Professions, Principal Consultant to the Senate Committee on Business, Professions and Economic Development, and a Health Policy Consultant to the Office of the former Senator Curran D. Price Jr. Dr. Clark Harvey serves on national and local boards in her current position on the American Psychological Association. She was appointed by Governor Newsom to the Master Plan for Aging Advisory Committee, as well as the Behavioral Health Task Force. Dr. Clark Harvey has received numerous awards, including a 2020 Minority Fellowship Program Early Career Award, the Henry Tomes Award for Advancement of Ethnic Minority Psychology, and the University of Wisconsin's Outstanding Woman of Color Award. There are so many other awards that Leondra has won, and she's also was recognized by the Sacramento Bee as a top influencer in the healthcare sector. Leondra completed her PhD in counseling psychology at the University of Wisconsin-Madison, go Badgers, and has completed her postdoctoral fellowship at the University of California, Los Angeles. So I want to welcome all of my speakers. Thank you so much for being here. We are going to go ahead and get rolling. We only have an hour today and there's so much to cover. So our first speaker will be Jonathan Butler. Go ahead and advance to the next slide. All right, take it away, Jonathan.
Thank you, Amanda, and I am certainly appreciative of the invitation to be able to present to such a wonderful audience of folks, thanks to the Department of Aging. Today, I wanted to talk briefly about some of the work that I'm doing as it pertains to disparities research. I want to title my talk Adversity and Health. The next slide, please. And for our discussion today, I want to talk about simply defining health disparities and health equity, cardiovascular disease, which I am certainly conducting my research in, the health of African Americans, particularly in a conceptual framework that I'd like to talk about. And most of my research is around adversity and psychosocial stress. And so I'd like to begin having a conversation about that as well as a call to action. Next slide, please. So what is health disparity and health equity? This is a term, these terms can be used interchangeably, but in terms of defining health disparity, it's a particular type of health difference that is closely linked with economic, social, or environmental disadvantage. Health disparities adversely affect groups of people that have been systemically experiencing greater social and economic obstacles to health based on their racial, ethnic group, religion, socioeconomic status, gender, age, mental health, sexual orientation, and gender identity, geographical location. There are a myriad of characteristics that define this. I want us to pay particular attention to the highlighted portions. By economic disadvantage, it refers to the lack of material resources and opportunities. For example, low income, lack of wealth, the subsequent inability to purchase goods, services, and influence. Social disadvantages define or refers to more generally to someone's relative position in a social pecking order. And by that, we mean individuals or groups can be stratified by economic resources, as well as by their race, ethnicity, religion, sexual orientation, and disability. And in terms of environmental disadvantage, this refers to residing in a neighborhood where there is concentrated poverty and or the social disadvantages that often accompany it. So health equity is the principle underlining a commitment to reduce health disparities and its determinants, and that includes social determinants of health. Next slide, please. I want to make sure that I frame my conversation around racism and how it may be the most important phenomena underlying Black health disparities, particularly exerting the ominous effects through institutionalized systemic stigma and exclusion. So historically structured racist practices and institutions are further reproduced by white majority policymakers, decision makers, administrators, educators, and health providers. And addressing health disparities from on an individual level misses the social, institutional, organizational levels underlying health disparities among Blacks. So I wanted to make sure to frame this with the context of racism as being that underlying Black health phenomena underlying Black health disparities. So we are living in a carefully crafted a system that's functioning as planned, successfully implementing social policies, many of which are rooted in racism. Next slide, please. I also want to focus our attention on some of my research that I do is around cardiovascular disease, heart disease. It's the leading cause of death amongst Americans. 46% of African Americans older than 19 years of age suffer from cardiovascular disease. Some of the leading risk factors of this disease, as we all know, high blood pressure, high cholesterol, diabetes, smoking, physical activity, obesity, and older age, which a lot of my research focuses on cardiovascular disease in the elderly. Next slide, please. So CVD age-adjusted death rates are 33% higher for Blacks than the overall population in the US. Blacks are twice as likely to have a first stroke compared to that of whites. High blood pressure is more prevalent in certain race ethnic minorities in the US, especially Blacks. Blacks have a higher prevalence of diabetes than whites over the age of 20, and then non-Hispanic Blacks and Mexican American women have a higher rate of obesity, a risk factor for CVD and diabetes. So a lot of my research really focuses on cardiovascular risk, cardiovascular disease, especially in older individuals and particularly in older women. The next slide, please. When we talk about health disparities, this is certainly the discussion that we need to start with in terms of life expectancy by race. As you can see, there's a significant gap, even between 1970 and 2010, of the life expectancy among whites and the life expectancy of Blacks. And the honest truth about this slide is if we just, held on to life or just, put a froze life for 30 years, it would take 30 years for Blacks to actually catch up with whites in terms of their life expectancy. So that is something that's very significant. And the first thing that we need to look at in terms of health disparities. The next slide, please. And this is looking at life expectancy between Black and white persons contributing causes. So in terms of heart disease, cancer, homicide, diabetes, perinatal conditions, Blacks have a disadvantage compared to whites. Blacks have an advantage over whites in terms of these chronic liver disease, Alzheimer's disease, chronic low respiratory diseases, and unintentional injuries and suicide. But these advantages are slowly becoming disadvantages as time goes by. Okay, the next slide. So what I want to focus on now is just this conceptual framework. So how do we sort of put this in a conceptual way so that we can understand how all these things play a part? So in terms of social determinants of health, in terms of racism, in terms of cardiovascular disease or health outcomes, how does this all come together? In the next slide. So this is, if you just look from top down, so the health of African Americans in the US is determined by the social determinants of health. And the social determinants of health and inequities involve poverty, incarceration, stress, which I'm going to talk about mostly today, violence, environmental exposures, lack of access to healthcare. And it is also determined by risk factors: poor nutrition, physical inactivity, obesity, high blood pressure, smoking, substance abuse. These risk factors result in morbidity, heart disease, diabetes, cancer, injuries, mental illnesses, and it leads to mortality. And one thing that we know in terms of health services, which are the policies, the access, the utilization, and the workforce, they either prevent or treat these risk factors. So it's important for us to identify that health services are certainly important in terms, especially policies and workforce and access, important for us to eliminate these risk factors which contribute to morbidity and mortality. The next slide, please. So part of my work is looking at adversity, and I wanted to just define what adversity is. The next slide. Adversity is the state of serious and persistent difficulty, calamity, or misfortune. Adversity is more than just one difficulty or setbacks, but it's a series of difficulties and misfortunes that keep you from achieving your goals or finding happiness or your quality of life. The next slide. What I want to focus on is a core component of adversity, which is psychosocial stress. The next slide, please. Psychosocial stress are, first I want to talk about that there are some positive stress, that there, stressful situations, our body responds to sort of positive stress, and that's the good stress. That's the stress that we need to actually, defend someone when someone is attacking us. But then there's these toxic stressors that we oftentimes have to deal with. They're either acute, which is stress that accompanies sort of an episodic negative life event, like a death of a loved one or suffering an injury or illness. Those are those acute stressors, but there are also these chronic stressors due to regular reoccurring events or environment or social conditions that are ongoing. Some of those things that we talked about in terms of social determinants, such as poverty, such as discrimination and the like. All this leads to clinical depression, HIV progression, sleep disturbance, and mental illness. Next slide, please. So when we're talking about stress, we mean that we're stressed out. We're feeling overwhelmed, out of control, exhausted, anxious, frustrated, angry, and it leads to sleep deprivation, eating too much of the wrong things, alcohol excess, smoking, not exercising regularly. All these contribute to allostatic load. And allostatic load is just the sort of progression of these chronic stressors through time. So it's the accumulation of all of those stressors, even from childhood up into adulthood, into older age. And that progression of stress can lead to detrimental health effects. Next slide. And this is basically just a description of this allostatic load, this concept that suggests to us that our brain perceives an experience as stressful. And then there's physiological and behavioral responses that are initiating, leading to this allostasis and adaptation, and that leads ultimately to allostatic load. So you just need to know that allostatic load is that accumulation of stress through time, and it has detrimental effects to our health. The next slide. So what I'm focusing on is that there are a myriad of stressors that each of us have dealt with: work stress, work family spillover, financial stress, discrimination, neighborhood stress, relationship stress, and all those contribute to a lot of the health challenges that we face later on in life. And a lot of the research just focuses on one stressor, like work stress and how it impacts your health, or just caregiving and how it impacts your health. But my research focuses on the combination of stressors that all have detrimental effects. So the next slide. So I've been able to look at how these combination of stressors affect cardiovascular risks like diabetes. Next slide. And basically what I found, I know this is a lot of numbers, but I would find that those who experience higher levels of stress versus those who experience lower levels of stress have a 2-time likelihood to develop an incident of type 2 diabetes. And this was a study that was assessed looking at women in the older ages of 75 and above. The next slide. And then we also looked at traumatic stress and negative life events, those stressors, for example, the death of a loved one, as I have alluded to earlier. And I wanted to look at how this stress actually impacts one's odds of getting obesity. The next slide. So what I found is, and this is again in older women, that those who experience one or more a traumatic life event will have an 11% odds of actually being more obese than those that have not experienced a traumatic life event. And the same thing is similar in the next slide regarding negative life events in older women. The next slide. So an important challenge for the future work is to go beyond assessing one isolated dimension of stress, as I have explained, but looking at multiple levels of stress and how that impacts your health. And so the next slide, what we've been able to do in the Nurture Center, which is the next slide you'll see, we've been able to partner with the YMCA and come up with a clinical trial that actually addresses the social determinants of health. And so not only looking at how eating right and working out determines whether or not you'll be able to lose weight, but we also think that there's more than that, that it is actually financial stress that contributes into one's gaining weight. And so we've created a clinical trial that will provide job opportunities for individuals to help them get a better job or get a promotion on the job that ultimately may contribute to a lessening of the stress load and ultimately a better chance of cardiovascular health. And the next slide, please. One of my favorite quotes is, in order to eliminate health disparities, to achieve health equity, we need leaders who care enough, leaders who know enough, and leaders who have the courage to do enough, and leaders who will persevere until the job is done, by one of my mentors, Dr. David Satcher. And with that, the next slide talks about my involvement with the soda tax, which is an establishment of so the voters of San Francisco voted on in favor of Proposition 5, which is to utilize the money that is spent on soda, the taxes on money that's spent for soda, to invest in the community. And they have created an advisory committee, which I am happy to serve as a co-chair of. And our job is to make recommendations to the mayor in terms of how that money is spent. Because of the policies, we're able to then provide funding into communities and able to address the social determinants of health. And so we have been able to fund programs that deal with workforce development, that deals with food security. All of that contributes to the social determinant of health. And as I have stated at the beginning of the talk, it is the racism, the systematic sort of racism that helps to perpetuate these policies that have harmful effects on our community. And it's important for us to provide policy that sort of addresses that. And the soda tax is one of the ways in which we can do. And the last slide that I wanted to just highlight the fact that we have lost a treasure in our community. And she has stated that the moment anyone tries to demean or degrade you in any way, you have to know how great you are. And we have to realize that we are great, that every human is to be valued, and that there are things that we can do, as David Satcher has told us, have the courage to do enough, and leaders that will persevere to the end, so that particularly African Americans will have a better quality of life. Thank you for your time.
Thank you so much, Jonathan. And I'm going to go ahead and pass it over to Lisa Tealer, Executive Director of the Bay Area Community Health Advisory Council. Hi, Lisa.
Hi, Amanda. I want to thank you and your colleagues for inviting me to participate in today's panel with Dr. Butler and Dr. Clark Harvey. Again, my name's Lisa Tealer, pronoun she, her. I'm going to just spend a little bit of time giving an overview of a grassroots organization, talk about membership and community engagement, talk a little bit about some of our programs and initiatives, particularly around seniors of color in San Mateo and sort of the challenges that we're facing and how we're going to continue to engage our elders and what's coming. Next slide, please. BACHAC for short is a 25-year grassroots organization. It was started by a group of African Americans residents in San Mateo County. And for those who are not aware, San Mateo County is just south of San Francisco. And as Dr. Butler had mentioned, they started this organization because of all the disparities and health conditions that they found from the community health assessment, cancer, cardiovascular disease, tobacco use, et cetera. Next slide, please. So we do our work by addressing health disparities in diverse communities across a variety of generations. Our focus is around awareness and education. We do this in partnership with a number of diverse organizations, and I'll talk about that. And we also try to do it in a culture of equity, innovation, and inclusion. Next slide. We have a core group of 30 to 40 volunteers. About 60% of those are 50 plus. We have about 7 part-time staff members and that are also bilingual in Spanish and Tongan. And again, as I mentioned, a diverse group of community partners that really serve as additional volunteers and also provide financial assistance to our organization. How we engage our members in the community is we have membership meetings monthly. They're open to anyone, second Monday for an hour. There's regular communication, either online, phone calls, regular mail. We actively seek out community members to participate and help us organize our events and programs, give feedback, participate in surveys. Our members are very diverse in terms of just their level of engagement. So not only are they involved with BACHAC, a number of them are involved and are leaders in other organizations like NAACP, the various Black sororities and fraternities. They are leaders in their churches and just involved in just a plethora of different organizations. And we also have members, for the context of this conversation, we have members that are representatives from AARP and the Alzheimer's Association and other senior focused organizations. Some of our programs, our oldest program is the community mammogram program that we started some 23 years ago in partnership with an affiliate of Sutter Health. A tobacco-free education, particularly around vaping and e-cigarettes among our youth of color. We also have a physical and nutrition program that we offer every year. It's actually this Saturday off to get it started, and I'll talk a little bit more about that. One of our major events is Soul Stroke for Health. This is a major family fun fitness event. Last year, it was the first time we did it virtually. And our honorary chair was Sunny Hostin of The View, where we expose people to different types of physical activity, provide them with health information. A member of our organizational members provide information as well. We also are involved in some of the other, what you may not expect from health organizations is some of those other social and cultural initiatives and activities. Last year, as you know, there was the census and voter education that we provided because our communities are hard to count or hard to reach. And so we participated in them because those are some social determinants of health. One of our newest programs is Wellness Where You Are. We started that in response to the pandemic, since we couldn't interface with our community as much face-to-face. This is a virtual sessions that we have throughout the year. We've had about 13 of those, and we just had one this past Saturday focusing on resilience, grief, loss, and mental health. Next slide, please. We're heavily involved, no surprise, to the COVID-19 efforts. We have a free COVID testing site, and that is a collaboration with San Mateo County, the College of San Mateo Nursing Program, and one of our faith-based partners, St. James AME Zion Church. And I want to just stop there for a second and say, this is really I think the success or the key ingredient of our organization is the ability to collaborate and partner with a variety of organizations that bring several skill sets and experiences to the table. Again, the county was providing the kits. The nursing program provided the nursing students. They did not have access to their regular channels to get their clinical hours. And then also to our faith-based community. Historically, that has been sort of the rock of the African-American community, where you got information, where you connected socially and spiritually with your community, and also seen as a trusted messenger. And so we've been doing that since November, every week. In fact, today from 4 to 7, we provide the free testing as well as PPE. We also do some additional education and outreach, particularly for our seniors. Not all of them are savvy on the computer. So phone banking is really important. They have questions, we give them information, etc. We do our online. So we have a resource hub on our website, webinars, email blasts, blogs, and then all the social media platforms. And then in a safe way, we do the canvassing. We do pop-ups. We provide information around testing and COVID and vaccines through food distribution channels and other heavy traffic areas. Next slide, please. We're also very involved in the vaccine education and outreach, and do similar as we are with the COVID testing and answering people's questions. We're doing the same, as well as we're going to be starting a pilot Promotora Navigator program to help those individuals who may need some additional support, particularly if they test positive, being able to navigate the systems, work with contact tracers, where do you go, et cetera, as well. And then again, I'll just pause briefly with this last bullet point. This is where we're talking about policy. And in the introduction, there was a comment made about, policy is really critical. We do a lot of programmatic activities, but it's really being able to be at the table with folks that are making those decisions, to bring those voices to the table, bring those issues, concerns, and solutions to the table. And so we have regular meetings, as well as several CBOs and other agencies with the county leadership, the health folks, the communication people, et cetera. Other activities, obviously panel participation, letters of support, and these are just examples of different organizations that we've partnered with. I mentioned the Black sororities, other Black healthcare professional organizations, and Alzheimer's Association. We do a variety of activities for them and also support some of their activities as well. Next slide. So I wanted to put in a little data, because as I was preparing for this talk, I wanted to just find out the latest information about seniors of color in general, and then get an actual breakdown. Unfortunately, we couldn't find the breakdown. There are roughly over 766,000 individuals in San Mateo County, which is an area that we cover mostly. We found out about 25% of those are individuals 60 plus, so 195 plus thousand individuals. Of those, about 88,000 are seniors of color. However, when we went to find data on the further breakdown of African Americans, Pacific Islander, Latino, et cetera, that it wasn't available. And I think that also can be a barrier to those individuals who are in policy-making decisions not being aware of the demographics in their area that they're responsible for. Now, San Mateo County folks are looking into this and seeing how they can get that data, but I think that's really critical. If you are having programs and initiatives and policies around communities, but you don't really have a good idea of who's in that community, that's problematic. Periodically, we do focus groups. And so last month, we did just a small focus group with some of our seniors of color, mostly African Americans, who themselves were seniors, were part of organizations that support seniors, or who are caregivers. And the end was small, but it was very telling. We posed 3 questions. What are some challenges and issues of seniors of color from their perspective? What are some opportunities and solutions? And then how can our organization, BACHAC, play a role in that? Next slide, please. Top challenges, and I'm sure for this audience, this should not be a surprise. Top of the list, of course, it was vaccine related. So vaccine availability and reluctance. And again, I want to just take a slight pause there, because just navigating the system to get on the list, going online, figuring out where you go, navigating that has been very problematic. And I can just speak personally. My 83-year-old mother lives with me, and she's somewhat savvy on the internet, but even I had to help her with navigating that. Another issue that came up was the lack of self advocacy and feeling empowered in healthcare environments. Mental health, so isolation and depression, and I'm sure Dr. Clark Harvey will talk more about that, and Dr. Butler also alluded to some of this data on that. A big one was finances. San Mateo County is part of the Bay Area, and it's very expensive to live here. The average rent is about $4,100, and the average income is about $200K. But about 30 to 50% of African Americans and Latinos don't make that kind of money. The lack of and also access to resources and knowing where to go. San Mateo County has quite a few programs directed towards seniors, but again, being able to track who's actually utilizing those programs and also pressure testing that against our members in our community. A lot of folks aren't even aware of some of the services that are available. And then of course, the caregiving, the financial and psychological burden of being a caregiver. A number of our seniors are also taking care of their parents and older siblings or relatives. And that is a stress point, which Dr. Butler mentioned about the various stresses that face communities of color, specifically African Americans. Next slide. So of course, we went right into a whole lot of discussion around challenges and issues, but what were some of the opportunities? First and foremost was acknowledgement of mistreatment and Dr. Butler alluded to this, racism, systemic racism, racism with the medical research and the healthcare system. And it was sort of a pivotal moment because as I was facilitating this discussion, some of the things that we were talking about that we read in history books around sterilization, around the Tuskegee experiment, et cetera, our seniors were actually involved in that, or they were aware of it, they lived it. So that's critical. Advocacy, both self-advocacy, advocacy from the organizations, et cetera. I talked about the technology piece, programming designed for and by seniors, being a conduit to resources, and again, holding the systems accountable. Next slide. Our next steps is the pressure test, and actually some of the challenges that came up, I went to the master plan and saw some alignment, but we'll continue to do that, continue to embed some of the things in our programming, continue to influence and advocate for the data, gotta have the data that influences the policy and where resources go, and the programming, continue to explore partnerships and continue to engage the community and continue with best practices. Next slide. In terms of our organization, what's coming up next, we just launched a blog. I talk about this month kind of reflection for the last 6 months. I did an open letter to the community when our brother George Floyd was murdered on television, and the impact that had on our organization and what we're going to do about it. As I mentioned, this Saturday, we have Off to a Good Start, which is physical activity and nutrition. And we're going to have some expert speakers. Dr. Curtis, who is the Deputy Medical Director for San Mateo County. We also have the Health Equity Officer, as well as someone doing a cooking demo on nutritious meals. Again, this is Black History Month, so we will be supporting some of our community partners on their Black History programs. And then next month, we don't have a date yet, but we will do a wellness where you are series on our session on seniors and COVID and the impact, what we're calling the suffering in silence, our seniors of color. Again, I want to thank all of you. I know that went very quickly, and if you want to learn more about our organization, this is the website. And without further ado, I would turn it over to Dr. Clark Harvey. Thank you.
Awesome, awesome. So many great things happening, and I'm so grateful to join my colleagues here that I'm presenting with. So I'm Leondra Clark Harvey. I'm the Chief Executive Officer of the California Council of Community Behavioral Health Agencies, and we represent mental health and substance use disorder clinics across the state that collectively serve over 500,000 Californians annually. And so I'm really grateful for my co-presenters and how they've really set the stage for the way that Black older adult physical health is impacted, and then also the importance of community resources and culturally sensitive treatment models to help address the health disparities that are prevalent among this population. Next slide. So I'll start off by sharing this photo with you. Oh, go to the next. Previous slide. Yes, thank you. I want to start off by sharing this photo with you. This is my grandfather, William Turner. He was born and raised in New Orleans, Louisiana, and he's a veteran who fought in the Korean conflict, and then he settled in California. He was a businessman, a former smoker, a cancer survivor, and now he's in his late 80s. Now, like his mother, he has Alzheimer's. He has also recently recovered from a COVID-19 infection that plagued upward of 70% of the patients that were in his care facility and 50% of the staff. So why do I share this with you? Well, because I think that as I reflect on my grandfather's story, he represents so many Black older adults. His experiences of racism, of poor coping mechanisms across his lifetime, poor physical health, and a lack of understanding and even a lack of belief about behavioral health conditions and treatments, it's all interconnected. Now, he's also had some protective factors, as we call them, and I believe that that's the reason that he's still alive today, which would include the fact that he's very much integrated and included in his faith community, who have been a tremendous support to him, his church. Because he's a veteran, he's received some really good care from the veterans hospitals that he's been associated with in California across his life. And he has family members who are educated and who advocate for him earnestly. So today, I'm going to venture into an area that's not often discussed within the Black community, but has significant impact on our psyches and how we operate. Next slide. And this topic is mental health and substance use disorder, collectively referred to as behavioral health or behavioral health conditions. Now, we know that behavioral health treatment is most effective when it's comprehensive and it's inclusive, and not just the individual, but the community as well. So that's why I like this definition, because it talks about the experience of an individual and a community and the fact that they have to work together to achieve behavioral health. Next slide. So I'll tell you, I'm a psychologist by training, and I decided to branch out. Go back to the previous slide, sorry. I decided to branch out from clinical work and research and pursue a career in advocacy. And it's really because of the families that I served. I actually never wanted to work as a mental health professional, and that's because my mother was a mental health professional. But the people that she saw in her private practice when I was growing up, they didn't look like me or my family. They didn't live in our neighborhood. So I grew up with this assumption that mental health treatment just wasn't for Black people. And that is the story of so many others in the Black community. I saw this as I practiced with racially diverse communities. And I felt frustration as a clinician because I was well trained to provide clinical services and interventions, but there was a barrier of stigma mixed with, quote, real life issues that we professionals call social determinants of health, as my colleague, Dr. Butler, reviewed earlier on in the hour. But it was ultimately these experiences that led me to a career as an advocate. So now, I'm really examining the intersection of physical health and behavioral health because it's important, especially among Black older adults. We know that persons with any behavioral health condition are more likely to have chronic conditions. Next slide. Such as high blood pressure, asthma, diabetes, heart disease, stroke. These also happen to be the health conditions that Blacks have the highest rates in and the poorest outcomes in. And this can result in high use of emergency rooms, and hospitalizations. Next slide. And when we look at some of the national statistics overall for diverse populations, we know that Blacks in particular experience less access to quality mental health services. They're less likely to receive the care that they need in a timely fashion, more likely to receive poor quality care when treated. We know that Blacks also delay or fail to seek mental health treatment. They're more likely to terminate prematurely. And after entering care, they're less likely to receive the best available treatments, particularly for depression and anxiety. This is a problem. Next slide. And if we drill down a little bit and we look at just, let's say, the Medi-Cal recipients of behavioral health treatment in our state, we know that 3/4 of these recipients are racially and ethnically diverse populations. This is despite the fact that many of these populations, in this case, Blacks, do not make up that same percentage within the population of our state. So there's overrepresentation here. Next slide. And as this chart illustrates, Blacks lead the way in rates of psychological distress. And then the other chart shows you that unmet need for that psychological distress and psychological issues, Blacks are also coming in high. But what's really interesting is that when you look at the data about Black older adults, they don't have the highest rates of behavioral health disorders. However, when they experience a behavioral health disorder, the impacts tend to be more significant, more deleterious. And researchers call this a race paradox. But why is this? Next slide. So for African American older adults, there has been a legacy of overt and covert racism within the healthcare delivery system. And these cumulative experiences of racism have resulted in mistrust of the system and generational stigma that gets passed down from generation to generation. In addition, structural racism has led to limited access to resources such as education, employment, healthcare, housing, political participation, on and on. And all of these taken together contribute to what my colleague earlier described as health disparities and the increased rates of mental health disorders such as depression, anxiety, and dementia. So when Black older adults get hit, they get hit hard, and then they have less access to quality of care. And if you throw on top of that the stigma and the hesitancy, it's really a recipe for poor health and poor quality of life. Next slide. And let's talk for a moment about how we kind of see this playing out today. Today with COVID-19, we know that COVID-19 has disproportionately impacted Black older adult populations. Public health campaigns were not robust in Black communities. There was rampant misinformation about, let's say, COVID not affecting those with higher levels of melanin. I heard this all around me. I got in a cab one day and the cab driver told me, hey, you're Black. You don't have to worry about, catching COVID because you have a lot of melanin. There was so much information. And we already know that as we've painted today, there's this historical mistrust that's at play. So are Blacks going to trust the healthcare system or the government? Or are they going to trust the information that's being spread in the community? What we saw with COVID is they trusted the misinformation. And this impacted their behavior, and it resulted in high transmission rates and high death rates. And now there's a significant hesitancy to taking the vaccine, even among those who work in the healthcare sector. My father-in-law sits on a hospital system board, and when they looked at their rates of employees who were refusing the vaccine, almost 50% of the staff refused, and the majority were Blacks. Blacks and other racially diverse populations are leery because, again, the historical mistrust that exists. Next slide. All right, so what can we do? It's a big problem, lots of issues. So what can we do to address this phenomenon? Well, we know that persistent health disparities within low income and racially and ethnically diverse communities can impede access to affordable, integrated, and quality health and medical services. So as my colleague, Ms. Tealer, pointed out, we don't have enough data on the impacts of Black older adults. And this really underscores the importance of making investments to integrate care, bringing together a diverse group of caregivers and community members, whoever's important in the life of a patient, to provide the best services. Training the workforce, this is so important. Ensuring equity by addressing disparities in order to meet the needs of underserved communities is critical. For example, bolstering programs that help older Californians meet their basic social and mental health needs, and do so from a culturally informed lens. This means that providers, all providers, should be trained about how to provide services to all people. That basic training is missing. That basic training is needed. We also must understand as providers the impact of racism. And my colleagues talked about this earlier. For Blacks, the effects of racism are felt daily. Racism also intersects with other forms of discrimination, including ageism, classism, sexism, ableism, and heterosexism. Therefore, the goal is really to aim to understand the lens through which individuals view their experiences when you're providing them care. So start the dialogue about difference. Educate yourself, get trained as a provider, and then be courageous. Start the dialogue about difference when you are interacting with your clients. Also, focus on resilience. There's been so much, statistics that have been shared that say, Black older adults are lacking in this, or the community is lacking in this. But the community is also very resilient and strong. This is a group of individuals who experienced slavery. As Ms. Tealer pointed out, some of these folks were existing and living in the era of the Tuskegee experiment. So there's a lot there to unpack, but they have been resilient. And so as providers work with Black older adults, really focus on the strengths, being strength-based. So supporting, strengthening, enhancing resilience, and really focusing on the ability to successfully adapt to overcome negative life events, such as stress and trauma. And Blacks have done this. Also a focus on spirituality and family ties, and strong positive racial group identity. These are things that are huge strengths among this population. We think about the African concept of Ubuntu, I am because we are. This is essential, and this is a lens that providers should work from when providing treatment to older Black Americans. Also integrating cultural norms and traditions, celebrate culture, organize community activities. Next slide. My colleague, Ms. Tealer, talked about, all that her organization is doing and reviewed many of the activities and everything they're doing in the community and hosting. This is really important to participate in these activities, but to also link that to integrating health information fairs, providing information to folks in a way that's not stigmatizing, in a way that allows them to engage with health professionals in a comfortable community setting. It's also really important to partner with community allies. Trusted leaders within the community can sometimes provide education and intervention and awareness better than medical professionals who are highly trained. So partnering with clergy, partnering with community leaders who Black older adults trust is really key. Providing that social support for older people and their caregivers as well. This is so critical and often overlooked. Black people are communal people for the most part. So individual interventions are not always successful. It takes a team of providers and often takes a family working with those providers to provide the best intervention. It's also important to understand that the way that family is defined by Blacks is different. So become familiar with the concept of fictive kin, which means that people are considered family as a result sometimes of just having long-standing relationships, not necessarily by blood or legal ties. So family is defined different. And the more that providers understand that, the better care they're able to give, the more comprehensive care as they work through a cultural lens. And then also, providing information to caregivers about long-term care and supportive services. Oftentimes the focus is on the individual and not those who are supporting them as they're seeking wellness. I would say in closing that, most African-American older adults have really developed some effective coping skills, spirituality, kinship networks. And this is how they've been able to be resilient and manage the experiences of racism and the effects of it. However, when needed, it's still really important to refer people to culturally competent mental and behavioral health services. Do not avoid making those referrals and making connections with people in the community that provide those culturally competent services. I wanted to end here with providing you all with a resource list. The slides will be provided to you, but here's a resource list and some great literature and interventions for working with Black older adults. I hope that you'll take advantage of them, and thank you for your time this morning.
Thank you all very much. We are going to move into the question and comments section. I think Maria will facilitate this. I see a couple hands up, so if you're accessing audio by the phone only, hit *9 to ask a question, to raise your hand. Otherwise, I see a bunch in the chat box. I do see several for Lisa. People are very interested in how they can get involved with your organization. So any advice you have, what's the best way to reach out to you to help get older adults involved with your programs?
Great. I will put my email address in the Q&A section, and people can definitely contact me that way, or call us at 652-3884. That's 650-652-3884. So thank you. I'd love to have you participate in our organization.
Great. And another question, actually, I believe that was for you, is a lot of Black seniors don't have internet or computers. How do you reach them?
Well, the great thing about Zoom is you can call in. So we encourage our seniors to call in. And if they're, having challenges, a lot of times folks, will help them, like over the phone, how they can navigate their iPhone if they have one, or they'll disseminate the information in other ways. So we definitely try to get information. For example, our meeting that we have monthly, I have a number of seniors that are not on computers. So I actually mail them the agenda and the monthly letter.
Great, thank you. Here's a question, I think, for any of the speakers. How can allies help with these disparities being experienced by older Black adults? Any takers?
Sure, I'll take a stab at it. I think there's a lot of things that can be done. I think one, just listening and acknowledging that community, and really getting to know those folks in your community, supporting organizations like myself, and making sure that they're a part of the dialogue when you're discussing policy or practices, is definitely a way to be an ally, to engage, or a lot of times just being in the room and acknowledging. So, for example, you might be, working on a policy or a program, and it says, wow, I've noticed that we don't have a person of color at the table. Let's make sure that we're being inclusive, and seeking out those voices to make sure that you are being inclusive and are being an ally. And there's a lot of different ways you can be an ally. There's like 10 different ways you can be an ally, and that I can definitely talk to folks offline more about that, because I do that work too.
Thank you. Maria, do you want to go ahead and see if we have anyone on the phone who'd like to ask a question?
It looks like we have two folks with their hands up. And Dominique, why don't we start with you? I've opened your line, so you should see an option to unmute, and then you can jump right in. Okay, Dominique, we'll give you a couple more seconds and we'll move on to Burdette Weimer. Your line has been open. Okay, Amanda, I think we might need a couple more minutes for folks. Wondering if there's any other questions we can turn to in the Q&A in the meantime.
Sure, I think I have a question here most relevant to Jonathan's work. Someone wondering about a tax on high sodium products. Any talk of that in the future? Any viability? Would that be a good tactic, in your opinion? You are muted.
Something I haven't thought about. Certainly something that may have potential, but in terms of policy, I think the soda tax has worked just because of sort of the efforts nationally around this work, and how there is a particular marketing strategy that are geared towards young people and African Americans and Hispanic communities around the soda industry, in terms of their marketing strategy to our communities, and how it's impacted our communities around diabetes. So that's how that was driven. So I'm not sure in regards to sodium, how that would work, but certainly a good idea.
Right.
Go ahead, Amanda.
Oh, no, I was just going to say we are at 11 o'clock. I'm going to go ahead and copy all the questions that we have remaining in the chat box. If you want to check the phone one more time, that's great. Otherwise, I'll hand it over to Kim for our wrapping everything up.
Well, I have the delight of thanking all of you and thanking our experts for Dr. Jonathan Butler, Executive Director Lisa Tealer, and of course, friend and colleague, CEO Dr. Leandra Clark Harvey. I just want to lift up so much your leadership that I was able to hear on programs and services and learn so much about, your advocacy with and for Black elders, the stories of resilience. Thank you, Dr. Clark Harvey, and also the accountability you're charging us all with to be anti-racist, to be inclusive, to really move us towards the California for all ages. So thank you so much for what you've done with us and for us today, this month, Black History Month, and every day of the year. We are so, so grateful for the partnership and honor your leadership. Thank you.
Okay, and please everyone, if you visit CDA's website, it'll take you to resources for Black elders for COVID-19. Our Equity and Aging Resource Center has all of the recordings from our previous webinars. It'll have the recording for this webinar as well. You can go ahead and register for next month's webinar on there. I will email everybody who registered for today's webinar all of the links to these things anyway. So look for that in your inbox. If we didn't get to your questions, I am going to try to find you some answers. You could always email us at engage@aging.ca.gov. I also would love to echo Kim's remarks there. Very grateful for these 3 phenomenal speakers. And I hope to see everybody next month for our culturally responsive policy programs for Asian and Pacific Islander older adults. Goodbye. Thank you.